I'm just going to give it another minute or two for people to continue trickling in, and then we'll get started from there. Thank you to everyone who's here and on time. Some of you I saw were early and in the waiting room as well. Thank you. All right, this looks like the people coming in have slowed down a bit, so I think we can uh, kind of get things going. Hello everybody. Good morning, good afternoon, good evening, depending on where in the world you're joining us from. Thank you for coming to the webinar. We're very excited about this particular session. This is the second webinar coming out from the Mental Health Innovation Network Asia Hub, and we're very excited this time to collaborate also with partners and friends from the Global Anti-Stigma Alliance. So today we are going to be talking about the cultural landscape and determinants of mental illness stigma across the Asia Pacific. And it's great that we have panelists here from across the Asia Pacific as well. Um, just a bit of housekeeping before we get going and I introduce our guests. You will notice that there is a Q&A box in your Zoom bar. Please use that to leave any sort of questions that you may have. We'll leave some time at the end for question and answers from through that box. Um, yeah, I will now introduce to you our panelists and our moderator for today. So our moderator for today is Dr. Chris Groot. He leads the Mental Illness Stigma Lab at the Melbourne School of Psychological Sciences at the University of Melbourne, which drives research, teaching, and public engagement programs that address stigma about severe and complex experiences of mental illness. And joining him on the panel, I, this is going to be a little bit long, so I'm going to just go through everybody. Um, do mind me. Um, we'll start with Elsa. Elsa Wu is a mental health advocate and psychology graduate from the Melbourne School of Psychological Sciences. Her honors degree research was conducted as part of Australia's National Stigma Report Card, with her thesis examining the stigma of borderline personality disorder in intimate relationships. And then we have Asami. Asami is a first-generation immigrant from Japan to Australia. She's a founder and director of Shapes and Sounds, which is and is a registered music therapist with over 18 years of experience working in youth mental health, trauma, and community sectors. Her organization, Shapes and Sounds, is the leading voice for Asian mental health in Australia that destigmatizes and normalizes mental health conversations in Asian communities. Atho is a PhD candidate at the Salisbury Hott School of Public Health within the University of Singapore. And her work is looking at the social construction and deconstruction of mental illness stigma in Asia and Singapore. She also teaches as a fellow of the College of Alice and Peter Tan. And we finally have Vicky, but last but not least, Vicky. Vicky has managed and overseen Mind HK's anti-stigma project, More Than a Label, based in Hong Kong, since 2021, and has a near decade long of experience in working in the mental health sector for various projects and organizations across Canada, UK, and Hong Kong. All right. Um, so with that, I'm going to hand it over now to Dr. Chris.
Fantastic. Thanks so much, Glenn. And thank you also for your instrumental work in putting this webinar together. I really think you've done an outstanding job for the Mental Health Innovation Network Asia. And I'd like to welcome everybody along to this webinar. I'd like to begin by acknowledging the traditional custodians of the lands from which we are streaming on. Right now, I'm at my home on the Bellarine Peninsula in Australia, and this is Wadawurrung country. And I'd like to acknowledge the traditional owners of the lands from where our panelists and attendees are streaming from today. I'd also like to acknowledge those of us here that have lived and living experiences of mental ill health and the expertise that has been contributed to inform our understanding of culture and of stigma and how these things are related. And we'll be talking about this today. Speaking literally about mental ill health or mental illness or mental health problems, I want to just provide a little bit of a note on language to begin with. I will use during my talks for the parts where I'm talking, for the most part, the term mental illness for the sake of specificity is why I use this and precision. As a researcher, I want to try and be very clear about what I'm talking about. But I do acknowledge, of course, that different people, and particularly people with lived experiences, have different preferences for how they would like their experiences spoken about and thought about. And so I'd just like to acknowledge that at the start. So now I'd like to follow on from Glenn's welcome and add my own welcome to all of our panel for today, and really looking forward to what I think is going to be a fascinating discussion on the topic of stigma and culture across the Asia Pacific region, and how culture sets the scene in determining how we experience stigma, how we express it, and how we might optimally go about responding to it across the region. So to start, I'd like to begin by defining our core topics and stigma in particular. And to do so, I'm going to reference what I think is one of the most significant pieces of work in the academic literature on this problem in a very long time, which is the Lancet Commission on Ending Stigma and Discrimination in Mental Health, which was led by Emeritus Professor Sir Graham Thornycroft and colleagues. And it outlines that at its core, stigma involves problems of knowledge and of attitudes and of behavior. So collectively, we might think and talk about these concepts in terms of public stigma being society's collective negative stereotyped beliefs, prejudicial affective responses, and discriminatory social behavior around mental illness. So, for example, if we were based on misinformation from movies or sensationalized news reports, for example, to believe that people with mental health problems are dangerous, then we might have the response of fear. And in turn, we might socially discriminate by limiting the amount of contact that we might have with people living with mental illness. Or to give another example, if we instead incorrectly misperceived people living with mental health problems to be lazy, then the prejudicial affective response might be one of irritability or frustration, irritation and frustration. And yet the social discrimination may also, again, be a common outcome, that marginalization and exclusion of people with lived experience. Stigma can also manifest structurally in terms of ideologies, laws, and legislation, policies that restrict freedoms and opportunities for people with lived experience. And if we're aware of all of these stigmas, then if we have lived experience in particular, we are at risk of internalizing that stigma, which can ultimately result in damage to our self-esteem, a reduction in our self-efficacy. It can exacerbate our mental health problems, and can cause a whole range of other negative effects. As we're going to discuss today, stigma about mental illness certainly extends to those around a person with lived experience as well, such as family members and friends, intimate partners, and even mental health professionals that work in the field. And indeed, I think one of my biggest lessons that I've really learnt this year more than ever before has been how in stigma research and practice in Western settings, we often tend to focus on stigma mechanisms as they pertain to individuals. However, as we will discuss in this webinar, certainly in the Asia Pacific region and in this culture, we will see that the collective really holds a very amplified significance. And by implication, then, if we were to address stigma and discrimination in the Asia Pacific region, then it's really necessary that we take culture into careful consideration, and that we worked in nuanced ways that maybe don't just champion individuals, but also champion their families, their groups, their communities, and so forth. All of those wrapped around individuals to address comprehensively this paramount problem of stigma. So there is, by way an introduction to the topic from me, let's begin our discussion, and let's begin by going to Singapore. And we're going to firstly invite Athel, Janelle Hugh Gearman, to share with us, Athel, some of your expertise. So you've been doing some exciting research in your PhD and in your work at the University of Singapore. And as I understand it, you're specializing in stigma and discrimination about mental health problems and how cultural factors are related to this problem across the Asian region. So maybe we can go to you first and ask you about what would you say are some of the really influential cultural factors that are involved in constructing and maintaining mental illness stigma?
Thanks, Chris, and hello, everybody. Thanks for taking time to join us today. Yeah, so basically my PhD research is really on social construction and deconstruction of mental illness stigma. Big term, I'll elaborate on social construction in a bit, but the key interest that I have is really to find the roots of stigma as best as I can, because my belief is we have to find the roots and then wrap our interventions around it in order for any interventions to be effective. So talk about social construction. Today my sharing will actually be based on a particular systematic review and meta-ethnography paper that I did together with our research team. Effectively, we try to find how stigma is actually constructed amongst Asians worldwide, and what's exactly social construction, what is it exactly about? Effectively, it's really about how knowledge and reality around stigma is actually constructed, or in layman terms, created. So the kind of stigma that we know, we take it as reality, but according to social constructionism, is actually constructed through social interactions where people create ideas and practices, where they observe like people with lived experiences, they behave or present themselves in a certain way. People interpret it, they create ideas and then practices, and when it gets passed down from generations to generations, it becomes factual. And all this happens, and it's contingent on social, cultural, and historical factors. So back to Chris' specific question on cultural factors. I managed to find some social, cultural, and historical roots on Asians. I'll label two key institutions, mainly structural, which has more to do with the governance and economical side of things, and also religious institutions historically that have created the stigma as we actually know now. We know that stigma, mental illness stigma, many different kinds of stigma, it has some moralization content. So when you talk about moralization, it's really about how we label people with lived experiences as, oh, the moment they have a condition, they have a diagnosis, just when we know that, oh, they live with a diagnosis means that, you know, we associate all kind of negative stereotypes to them. So there's some moral content, that some sort of quote unquote badness or to it. But yeah, because of this kind of moralization, people end up withdrawing, you know, and amongst Asians, we know that there's a lot of shame and loss of face amongst Asian sufferers, including people associated with them. But why and how did this come about? Like why do people actually end up, you know, labeling people with lived experiences as displaying poor character or bad behavior? So I managed to actually track back structurally. I found some data in our systematic review and meta-ethnography on how historically colonialism. I'll quote Vietnam as an example, where actually the roots came from how back then in colonialism, the setting up of the very first mental health hospital was actually labeled as like the crazy house, and it was used to actually incarcerate people. This might not be new to us. Yeah, so back then, I think in Melbourne it might be the same. Yeah, I learned that in a museum last year when I visited. So, you know, it was back in Vietnam, it was labeled as crazy house, and it incarcerated people with lived experiences. And, you know, it created sort of a historical trauma since then, where the term mental health became very negative amongst the Vietnamese. And this piece of work is actually not just based on Vietnamese in Vietnam, but it's actually based on Vietnamese in United States. So they have actually migrated there. And this historical trauma continues to actually live with people who have migrated over there. So, you know, yeah, so it's not just about Asians in Asia, but Asians who have migrated like second, third generation. So it shows us how entrenched stigma actually is. And yeah, so this particular example actually show us how the association with you know, by using, say, law enforcement governance in, you know, incarcerating patients have led to some sort of association with criminality. In sociology, we call this symbolic interaction. You have an object, you attach meaning to it, so people just keep associating, you know, people live experience to that. And the other thing is, the other learning lesson that we can have here is that labeling of all these mental health hospitals, all these terms matter, right? So it's good that, you know, currently we have most countries perhaps have already changed their mental health hospitals to something that's more palatable. So that's a good start of sorts. But on the governance side of things, perhaps we might sort of need to look into not using law enforcers, for example, to sort of de-escalate situations if people with the experiences might be in distress and so on, to sort of dissociate, you know, mental health with criminality. So the other structural reasons has quite a lot to do with Confucianism in Asia, especially for contexts like in more Chinese context, in Korea as well. I found the notion of Confucianism, because again, you know, there's moralization, because Confucianism emphasizes a lot on things like good moral character. You need to be a balanced individual. You need to have self-control. You know, all this has like, oh, the notion of good moral character. But unfortunately, when people live experiences, be it just by the way they look, for example, in schizophrenia, if they have a blank affect, they might look a bit like it's just blank affect, right? But to lay people, they might look a bit scarier. Or in certain cases of distress, you know, behavioral symptoms might come out, and then they'll be labeled as bad, you know. So because all these symptoms sort of run in contrary with from the notion of good moral character, so stigma comes about that way. And then further down the road, I also found some industrial roots to stigma as well. So again, tied back to Confucianism. The other notion is, the notion of hard work. You sort of cultivate good character through hard work. So that sort of shaped and drove the industrialization success in certain countries in Asia. And the notion of hard work created stigma as well. This ties into Jerry Young's work on What Matters Most framework in stigma research, where it says that people are stigmatized more if they are unable to fulfill what matters most in that context. So in those states where Confucianism is emphasized, hard work and earning money is emphasized, and this is particularly important amongst Chinese and Koreans culture. And because of that, when people with lived experience are unable to work as hard or be so productive, so to speak, they are stigmatized. And finally, religion. So religion is a very big thing in Asia. So I found some religious roots to stigma as well. Again, religion typically emphasizes on moral values again. So on the note of religion, in certain countries where there are, whether is it a religious state or where a dominant religion is actually practiced, people's interpretation of religious ideas, that was what we found. People's interpretation of all these religious ideas sort of constructed stigma. So what happens here is that people tend to associate symptoms of people with lived experiences to things like sin, demon possession, or things like karma, for example. And this results in not only people with lived experiences being stigmatized, but their family members also get stigmatized, because usually things like sin, demon possession, or karma has that notion that, oh, someone in the family must have done something bad, or this person with lived experiences must have done something bad. This is the reason why, we don't just stigmatize the people with lived experiences, but also their family members, for example. Yeah, so these are some key factors that I found. And perhaps one last one, in Asia, people tend not to want to talk about mental illness, because collectivism, we always talk about collectivism as good, right? Like people support each other. But when it comes to stigma, it's actually on the contrary, in a sense that because networks are so enmeshed and gossip happens very often. Yeah, this is the reason why people can't tell anyone. Yeah. So I basically sum up 24 pages of manuscript in this few minutes. Yeah.
Thank you, Ethel. That is a wonderful summary of your extensive work. And many of the things you were talking about there reminded me of the event from which this webinar has sort of emerged over time over the last few months, which was an event put on by the World Bank and the Korean government in Korea, a stigma summit where members of, I think, both the Mental Health Innovation Network, the Global Anti-Stigma Alliance, and others from around the world came to Korea to talk about stigma and the potential solutions. And one of the things that I did was write about and present about the cultural implications that need to be taken into account, or should be taken into account, to successfully address stigma. And there's a few things that you said that just reminded me of important, what I thought were important points at the time. So you mentioned Confucianism, for example, and the emphasis of social harmony and of behaving in responsible, honorable ways. And so at the time I was wondering, I wonder if reframing help seeking for mental health problems, not as something shameful, but in our stigma work, which often involves public messaging, reframing in that message the act of seeking help as something that contributes to social harmony, that is honorable, that does contribute to family harmony. From your perspective, with your research, would that potentially be a promising avenue to explore?
That's a good question. Haven't quite thought about that, but it sounds like quite a feasible plan. But knowing Asians, uh, so one of the other key thing that I found in this is really about reframing the language. So I didn't focus too much on that. But a big part of the emphasis of the paper was it just dawned on me that you know because Asians emphasize a lot on doing, yeah, not just talking about it but also the doing part. And what I found in our paper was basically that we need to put back the emphasis on helping them to actually fulfill certain important roles in life. That might work better. So somehow family members or people in society might not care about them so much until they are productive of sorts. So I would think that for along with reframing the notion of like seeking help is a way to maintain harmony, uh that definitely would work. And along with that, I think the family members and people around them might care more if they are able to fulfill the kind of roles that particular context actually value. Yeah, for example, their family
So
roles,
highlighting those
work roles.
strengths,
Yeah,
highlighting those
yeah,
strengths that people with lived experience have. Yeah, I
right.
love it.
Yeah, yeah.
So you also mentioned the diaspora, and so this makes me think now of ALSA, who I work with and have had the pleasure of working alongside for a number of years, both um, uh, on stigma research and in teaching our very large undergraduate student population at the Melbourne School of Psychological Sciences. Elsa and I have worked for a couple of years now on governing our third year psychopathology unit, which is all about mental health and mental health problems. And Elsa, you've got the unique perspective of being a Chinese Australian immigrant. Um, and it's just been amazing to watch you grow in your academic role and to also grow in your lived experience academic role, embracing your identity as a consumer academic and contributing to several projects, both teaching and research from that perspective. Um, I'm wondering if you could talk maybe a little bit from your unique perspective about what sorts of cultural factors contribute to the stigma surrounding mental health in immigrant Asian communities, and maybe how they impact. We were just talking about help seeking, so maybe how that might impact individuals seeking help, seeking treatment or support.
Sure. Thanks, Chris. Hello, everyone. I'm Elsa. It was very interesting to listen to what Ethel had to say earlier, and sort of thinking about it from um a lived experience perspective. And I guess that's why I am keen to um continue my work in academia and research to sort of, I guess, make a difference on the ground of what I experienced personally, but also what I observed, and sort of hoping that um, others don't experience the same hardships. And at first, I guess when I heard of stigma, um, I knew it was a thing, but like when I mentioned it to my Asian parents, they're like, "What is stigma?" Everything's stigma, or like there's no like stigma itself is even a stigmatized concept. Um, in that it's really hard to actually explain stigma, and I thought that was an interesting place to start because I was trying to translate stigma into Chinese for my dad, and we just couldn't find a word. Um, and it was sort of breaking it down into the knowledge, the beliefs, the attitudes and behavior. I tried during our whole year of the honors thesis, I tried to explain to him what I was writing about. And I think So I think it's a really important conversation to have because over time I've realized that stigma actually plays a huge role in how I guess the Asian population experience mental illness, in that it can exacerbate the symptoms of mental illness itself, but also um, become a barrier to help seeking. And so I guess the first thing that really spoke to me, and Athel's mentioned this already, the role of, collectivism, but more Confucianism. And I think especially for young people when they are sort of still very much part of the family unit, um, those values are a lot more endorsed, but also um, in a way they are more enmeshed with the family unit versus someone who has moved out of home. And so I guess a huge part is the shame and the secrecy surrounding not just the experience of having mental illness, but also seeking treatment for it. And I think sometimes it's important to distinguish between the two, um, and how sort of the moral side of things that Athol was getting at, the interpretation of, I guess, mental illness being a character flaw or a weakness, or I guess if you're a child, then your parents might feel like they've done something wrong, or try to sort of explain your symptoms and behaviors in a way that um, downplays it as a symptom, and rather it's sort of a flaw with the person. And I guess um, I feel I feel like especially for immigrants where um I think I'm a second generation immigrant. Anyway, I came here with my parents. I think that makes me a second generation immigrant. But I came here when I was 10, and you sort of look at your first generation immigrant parents, and they're working very hard to provide you with a better life or a better education. And the last thing you want to do is to then sort of not make them proud or make them feel like you can't be as productive as Athol was sort of referring to, given all the sacrifices that the family has made for you. And so I think all of that also feeds into this very significant cloud of internalized stigma. And I feel like that's somewhat unique to maybe the Asian experience or the Asian immigrant experience. And I guess as a result, sort of it is well known that shame, guilt, and shame and secrecy can have devastating effects on the symptoms of a range of mental illnesses. But also, what I personally found especially difficult was accessing treatment, especially as a young person. I guess that might be just due to the convoluted healthcare system we have in Australia, but also, I don't know what it was, but from not a very young age, but like, in the later years of high school, I knew that I needed to get treatment, but it was difficult to get that, both accessing services financially, but also, needing to have my own Medicare card and going to see a therapist. But also, what I found during that was, at that time, this was probably like more than a decade ago, it was very difficult to find service providers or practitioners that understood how mental illness was experienced uh, in a cultured way. And especially with young people, a lot of treatment wants to focus on things like family therapy or providing the parents being the support system. And it's a bit difficult to do that if one, your parents don't endorse that you have a mental illness, and two, they're not, they're not helping. They like even they might be doing more harm than providing support. And I'm just really fortunate that over time I've had to do a lot to sort of educate my parents and on how they can support me. And a lot of the time it's not about supporting me, it's just about like just accepting what and I can get my like helpful support elsewhere. But um so that was, I guess, but it took a very, very, very long time to get there. Um and personally for me, I guess it took a very long time to almost make them for them to realize that I was very severely ill. And I think that's also a very important thing. And again, it's the affecting your productivity. I went away to uni throughout this whole time. I was, doing well, but once I sort of put down everything and stopped being productive, then it was like, oh, okay, something might be wrong. But you're always sort of struggling to balance you already feel bad enough about having a mental illness. And so you're trying to sort of cover it up per se by trying to be productive. And I think that was sort of a double-edged sword because I let it go on for that long rather than sort of, you know, throwing the towel the first day that I knew something was wrong. But in hindsight, uh, I think that's also very important in order for especially young people to get early treatment because we know that outcomes are so much better when treatment's accessed early. Yeah.
Thank you so much for that very authentic and very candid reflection, Elsa. And I think you've just captured um, so many important points that you mentioned. Then just really resonated the point about the mental health systems and services, and that they weren't necessarily geared to or didn't have a culturally informed capacity to help you at the time. And hopefully things are moving in the right direction. And that's something I'd like to come to Asami and ask about very shortly as well. Something, Elsa, that you mentioned and Athel also mentioned was this idea of shame for families. And I found that very interesting because Elsa, you're speaking from a Chinese heritage perspective, and Athel, I know your research was, whilst overall in an Asian setting, quite cross-cutting in terms of cultures. And for me earlier on this year, what I was really fascinated to learn more about is how within even just Korean culture, for example, there are so many different aspects of culture and so many different ways in which this plays out. Um, in terms of stigma around mental health. There's a lot of nuance here under this banner of sort of Asia Pacific culture, but there's also some commonalities as well, and this shame one seems to be one. I was wondering, Elsa, have you seen that play out in terms of sort of concealment of mental health problems within a family? Have you sort of observed that at all? like a pressure to conceal mental health problems?
Yeah, definitely. And not just concealing the experience of it, but also receiving treatment for it. And um, I think when it comes to that, the shame is um, like some elements of the shame would be similar to, I guess, what is experienced in the Western culture. And it's not like, stigma is experienced completely differently between Western and Eastern cultures. And it's not like you don't have shame for, um, people from Western cultures when it comes to mental illness. I think it's um, for things that it when it comes to those elements that we talk about when like what leads to people to, have stereotypes and prejudice. Um, and so elements like being unpredictable or being perceived as dangerous, or uncontrollable and the responsibility. It's it's quite positive to see that um certain conditions like anxiety and depression are sort of being talked about a lot more in um in or in the Chinese community. And with that, I guess it one of the for some people, one of the sort of the biomedical explanation model really alleviates the responsibility part of it. That sort of then removes the shame factor of the condition being a um, moral condition. And I find that that's been really effective in terms of um, how others have sort of described their experience of it then becomes sort of more okay to disclose. But I think when it comes to um, more complex and severe mental illnesses that are not really talked about or portrayed as accurately by the media and even the profession, that then becomes very hard because, again, there's that unpredictability element to it, because people don't really understand it and therefore they don't know how to explain it or where it comes from, and therefore then they're more likely to conceal because they don't understand it.
Mm,
Yeah.
feeling misunderstood. I do want to come back to you to ask you about the question of representation. I think what you've just raised there around the representation of people with lower prevalence experiences is so important for stigma reduction. And I do want to come back to you about that one. But before we lose the thread of thought, what I'd like to do is come over to Asami now. Asami, you're the founder of Shapes and Sounds, an organization that helps young Asian people in Australia with their mental health. And we've just heard Elsa talking about her experience of the Australian mental health system. I do want to, maybe I can ask you a couple of questions. So one, if you could firstly maybe tell us about what Shapes and Sounds does. And secondly, tying into what Elsa was asking, then I suppose I'd like to ask you, are mental health services in Australia aware of the needs and the preferences of young Asian Australians, or are there cultural nuances that are overlooked? Is there more resourcing and capacity that's needed?
Thanks, Chris, and thanks everyone on the panel too, and everyone joining us today, although I could only see your little name rather than your face. So lovely to be here. So Shapes and Sounds, we're a community-based social enterprise here in Melbourne or Naarm, Australia. And our work is about destigmatizing mental health within the Asian community here. And the reason why we do that is because in multicultural countries like the US and Australia, we have the lowest engagement rate with mental health services, or I should say, we are the least likely as a group to be accessing mental health services. So we really want to kind of address that and shift that as well, probably based on our own lived experiences and our families and our peers as well. Shapes and Sounds, we offer two different streams. So on one side, we're working directly with the community with programs such as our creative arts therapy programs that we run for international students from Asia. And we offer creative arts therapy, art therapy, and music therapy, not just because I'm a music therapist, but we see that as perhaps one way in which we can help people to overcome stigma as well, to engage in strengths-based activities. Something else that we provide for the community is our Asian mental health podcast. And the reason why we started this was we learnt that apparently the vast majority of young people, like 80% of young people, access mental health information through podcasts over any other medium, not friends, not family, not teachers. And so we really wanted to enter this space and have conversations about mental health from a cultural perspective, a culturally responsive perspective, to normalize conversations about mental health from people who are Asian and trying to represent the broad diaspora here as well. So they're kind of what we do community facing. We're really trying to find different ways to try and engage people in the conversation around mental health. And then our other stream is really trying to provide cultural competency trainings to mental health practitioners and mental health organizations. Places like Headspace and NEMI are federal organizations here in Australia, and we really want to support them to understand the needs of the Asian community. There are reports and documents that highlight that although in Victoria, we might have a very comprehensive suite of services available through community or public or educational settings. Like, we do provide the services, but what is lacking is no organization is actually trying to kind of do the outreach and engage and address the stigma that is holding a lot of people back from accessing supports. So we want to help them to understand that. We want to help organizations feel confident and resourced in supporting the population. For those outside of Australia, the broad diaspora here, the Asian community makes up 18% of our population. That's 1 in 5 people in Australia are Asian. So we see that our work is about trying to be a bridge between the Asian community as well as mental health services, and trying to kind of not only engage one side of the conversation, but also help organizations understand our needs better, exactly as Elsa mentioned.
It's such valuable work. As you were just speaking then, I was thinking about my experiences at the University of Melbourne this year as what's called an academic advisor. So every academic member of faculty will work with a group of students for their entire time that they're enrolled in our program, so that every student has somebody they can go to at some point if they've got a problem, if they want some advice, and so forth. And we meet once a semester throughout their entire degree. This semester, I really was struck by what seemed to be a theme with many of the Asian students with whom I was, international students with whom I was meeting, and hearing about social disconnection and isolation and the challenges with adapting to study in another country in a second language, being away from home, being disconnected from friends. There obviously being some problems with mental health and well-being, but maybe not really having literacy or insight into that, or if there was, maybe not really knowing how to reach out for help or who to reach out to help to. And so you mentioned outreach just before as a necessary component. I'm wondering, how do you take culture into account when you do that, when you're engaging in those outreach activities? How does culture, I suppose, inform your approach?
This is such a great question, and something we've thought about so much within the Shapes and Sounds team as well, because there's so much that obviously mental health services are all umbrellaed by psychology. And first and foremost, we begin by acknowledging that psychology originated as a Eurocentric framework and a Eurocentric practice. And it's only until very, very recently that perspectives from people of other cultures, other identities have kind of been incorporated in the research and the evidence base that we kind of formulate all of our ideas about mental health on. So what I mean by that are things like our understandings around so-called what is healthy attachment, or what is love, what is happiness, what does a healthy boundaried relationship look like? What about parenting styles? All of these things, so many of what we deem as kind of correct and valid often have come from very Eurocentric norms as well. So first and foremost, we kind of start there, acknowledging that there are so many things that we can learn. There are so many valuable tools that are on offer, but is everything that we know, everything that we consider evidence-based, relevant for the groups that we're working with? And sometimes just sitting in that nuance helps. It helps us to formulate our messaging as well. Another thing that I think a lot about in terms of culture, especially when we deliver our creative arts therapy programs, is this idea around freedom in expression. And what I'm kind of talking about is when it comes to art and music, for so many of us from Asian identities, there has often been a strong focus on perfectionism or performative ways of engaging in creative mediums. So then we try to remove all of that performativeness out of engaging with art so that people can really focus on pure creative and emotional expression through different mediums. And we do that through things like we never ever take photos. The language that our facilitators use in our sessions takes out anything performative. We never say, oh, that's a beautiful piece that you've created. Everything is like, oh, what does that mean to you? What does that feel like to share today? And so really being very nuanced around language is something that we're considering a lot when it comes to culture and how we deliver our programming.
I love that idea of engaging through those creative programs. And that sounds like a really, very effective way to do outreach as well, when maybe sometimes, thinking about things like even face concern and sort of indirect ways of dealing with quite confronting topics like mental illness, that can be a nice sort of sort of indirect way to open up the door to help seeking and to support. And I will definitely come back to you with some more questions, Asami. It's just been such a pleasure to learn about your organization. And one of my students this week already mentioned to me that they had been in touch with Shapes and Sounds. I recommended to them that they did reach out to you, and they said, "Oh, I already have."
Really?
There you go.
Okay.
Yeah,
That's
yeah.
amazing. Thanks.
And so, speaking of expression and art as a way of working culturally around mental health, I now think of Vicky. Vicky, I was so interested to hear earlier on this year. I was just thinking it was at the Global Anti-Stigma Alliance meeting in Reykjavik that was just before the Together Against Stigma meeting that I heard about the art exhibition that your organization, Mine Hong Kong, was running the exhibition titled More Than a Label, and it was very much an arts-based stigma reduction program. And so maybe let's continue exploring this theme. Can you tell us about that work that you've been doing?
Sure, of course. Thanks, Chris. Thank you for the introduction. So before I give a brief explanation about the exhibition, let me briefly introduce the anti-stigma campaign More Than a Label. So we're Mind Hong Kong's anti-stigma campaign in partnership and sponsored by Mindset and sponsored by Manulife. Our goal stems from kind of changing and influencing the public's perception towards people with diagnosable mental health conditions and people who feel that they've experienced a mental health condition, because we understand that within our society in Hong Kong, getting a diagnosis can be very difficult and challenging and timely. And we don't want to minimize those people's experience of not necessarily having a mental health illness just because they struggled getting a diagnosis. So the campaign encourages the public to look beyond the stigmatizing labels associated with mental health diagnoses. And we do this through personal stories of mental health journeys. We kind of want to showcase the realistic portrayals of people who have faced mental health problems and recovered. And we want to highlight that it really can be anyone. The current statistic for Hong Kong is 1 in 7 people. And within the population, that's a lot of people. And we want people to feel that, oh, when they see our ambassador stories, it could be themselves, their best friend, or their colleague. And we hope to raise awareness of the stigma towards people with mental health conditions and kind of celebrate the strength and resilience that it takes for people in recovery, and to educate and equip the public with mental health knowledge. And as we all know, the world is, full of labels. Though the word label itself is neutral, many labels tend to not be. We tend to label people based on their stereotypes, negative, inaccurate perceptions, rather than their true selves and what their authentic stories are. And we do believe that labels have the power to affect our attitudes and behaviors, and only strengthening the stigma around mental health with these negative perceptions. So this is obviously not just a Hong Kong phenomenon. That's why we're all here. It's a global issue. So people with diagnoses, people diagnosed with mental health conditions can commonly be labeled by their diagnoses or the negative stereotypes associated with mental health, such as being lazy or being violent, which has the power to define who they are as a person. So we're aiming to challenge these inaccurate representations and labels of mental health conditions by showing real stories of people who have a mental health condition or illness and still live a very fulfilling day-to-day life. So I know some people are wondering, do people in Hong Kong really have stigmatizing assumptions about individuals' mental health problems? So Mind Hong Kong did a survey back in 2023. And though we did find some good news that the public awareness of mental health in Hong Kong has been steadily increasing, I think in part of the pandemic. That was our little silver lining. It made everybody think about their mental health as we couldn't go anywhere. But it did also reveal, less good news about finding that the stigma towards individuals facing mental health conditions remains significant in both the workplace and within your day-to-day life. I think some of you mentioned about how it is a collective perspective. The stigma isn't just something that affects an individual, but our society as a whole. So through our research using the CAMI scale, which stands for Community Attitudes to Mental Illness, our survey did indicate that stigmatizing assumptions about people with mental illness remain pervasive. The number of respondents that agreed that there is something about people with mental health illness that makes it easy to tell them apart from people without mental illness actually increased from 11.13% in 2021 to 62% in 2023. That's a big jump. So from that's a huge jump, and it's upsetting that though people have more knowledge about mental health, the stigma seems to have stayed. There was also a 12.9% increase from 2021 in the number of respondents that agreed that people with mental health problems should not be given any responsibility. So these statistics kind of highlight the underlying need for anti-stigma work in Hong Kong. So back to the exhibition, I know that was the main question. So the exhibition that our campaign held was called Here and Now, Bring Back Memories, Places We've Walked Together. We had commissioned a local artist called Aaron Hung to create 4 unique art pieces surrounding our ambassadors' stories of mental health recovery. Her artwork is called Snakes and Ladders, and the series featured 4 illustrations inspired by the classic board game Snakes and Ladders. And it was actually inspired by her son. She saw him playing one day, and he threw a little tantrum about having to go up and down the board game. And she thought that it was a really beautiful allegory for the ups and downs within one's mental health journey and kind of life at large. So we really want to highlight that mental health recovery is not a linear process, but a dynamic journey that consists of ebbs and flows. And we hope that with the concept of, here and now, we can shed light on mental health's evolving nature with a dual focus for one's space and time, and celebrating the resilience and strength of people in recovery. So the interactive exhibition also encapsulates the essence and theme of celebrating the power of companionship. So in Chinese, it's 陪伴同行, which is something that we really wanted to tie alongside with our exhibition. Being in Hong Kong, we wanted both the Chinese and the English to kind of encapsulate how mental health recovery feels for our culture. I know Chris mentioned earlier that Hong Kong is a melting pot of culture. We do want to highlight the various different cultural experiences that does exist in Hong Kong. So the exhibition showcased a collection of real life stories from ambassadors presented in written form alongside photographs depicting significant moments and memorable locations throughout the recovery journey. So I guess what More Than a Label in Mind Hong Kong is trying to do is to normalize the topic and conversation within Hong Kong and within our culture in both Chinese and English. I think that's really important for us to be able to continue to destigmatize in a place that is so rich with various cultures, because I feel that we can't talk about something that we don't necessarily have the language or knowledge to. And I think something really impactful that an ambassador actually recently shared with me is that we are actually personalizing a percentage, which I think is a really beautiful way of turning the narrative towards us and kind of flipping the script. And we want our ambassadors and people with lived experience to kind of share their side of the story.
That is wonderful work that you're doing there in Hong Kong, Vicky, and I love that you ended by talking about how you centered this around ambassadors with lived experience. That obviously is central to stigma reduction. We know that social contact is overall the most powerful means of reducing stigma, and I think everybody's been talking to the fact that whether we live with mental health problems more or less, we are rich and complex individuals that have got so much to offer. And being able to give those around us in communities, in culture, an opportunity to interact and to experience being with and enjoying their fellow person, whether they've got mental illness or not, is such a great way to break down those barriers, to address those stigmas. And let's face it, when you think about social exclusion, it's not just the person with lived experience who is detrimentally affected by this. It's everybody. It's everybody who's missing out on those opportunities to interact with those wonderful people with lived experience. Their lives are diminished as well because of this stigma. I'm mindful of time, and we've got some questions in the Q&A that I can see. There are a couple of things that I wanted to talk about. I wanted to maybe what we'll do is address the Q&A first, and then I want to pose a question to everyone as we move towards a close, and we're going to talk about the new World Health Organization Mosaic Toolkit, which was developed by Professor Petra Gronholm and colleagues. And central to it is, of course, championing people with lived experience in reducing stigma about mental health problems. And I want to come back to everybody to ask you in due course, if you had one recommendation, knowing that so many of our viewers are representing services or stigma reduction initiatives, one recommendation for how culture could be taken into account to in-service delivery to address stigma, what would that be? But in the meantime, while you mull on that, I'm going to firstly come to Athel with a question that is in the Q&A. And Athel, you might have already seen this one. This is submitted by Karen. Thank you very much, Karen, for submitting this question. And so Karen asks, says, thank you so much. Athel, based on your research, is there evidence on whether the roots of stigma are exacerbated for particular groups within society? For example, women, ethnic minorities, migrants, and what factors might drive these differences?
Yeah, thanks, Chris, and thanks, Karen. I could actually answer that question and one other question further down. So my answer is yes to that question. Usually it's exacerbated for minority groups. So I did find some insights on the fact that say women, for example, in more patriarchal kind of context, they actually experience stigma even more, or migrants into Western kind of context, Asian migrants in Western context, for example, they usually there's intersection between their mental health experiences as well as structural conditions that actually, because they usually, say for example, migrants, they experience a lot more financial issues due to their status for some of them. Yeah, and for that matter, I mean, we call it double whammy or triple whammy, right? Like depending on how many minority status that you have, intersecting with the structural conditions, stigma becomes even more serious. I would like to take the opportunity to also answer one of the question about representation of Asians. In my study, I actually tried to include, it was in the review itself, we try to be as comprehensive as possible. I actually included all the countries in my search term. But when it comes to research on social construction of stigma, there's more focus on the more, East Asian kind of context. But I had some stuff on Middle East as well as some stuff on Israel. I had some points on South Asia as well, like India, Bangladesh, and things like that. Yeah.
Fantastic. Thank you, Athel, for that excellent answer. I can see that more than one question has asked about the distinction between high prevalence, more mild to moderate experiences, and lower prevalence, maybe more severe and complex experiences, and their implications for stigmatizing and for stigma reduction. I'll give an example here from Jeffrey, who asks, what is happening with the distinction between lower mental distresses like anxiety, depression, PTSD, and more serious mental illnesses like bipolar, schizophrenia, borderline personality disorder, and psychosis, and basically promoting the idea that we all have mental distress, sometimes needing some treatment versus the very small number of serious mental illnesses. I think the lay therapist focus can help drive things in that direction. Lay therapy for the vast community of the distresses versus professional psychology for the small group of mental illnesses. Distress is not illness. So this raises a very interesting question about, I suppose, dichotomizing the spectrum of mental health problems and what the implications might be for stigmatization in that respect. I can also hear an idea in there about, can we sort of better equip the individuals and the community to play an instrumental role in helping ourselves and each other with mental health problems? Is there anybody that would like to check in around that first that first issue around this, mild and moderate versus more severe type of experience. Vicky, I can see you're unmuted, so I'm feeling like you might have an answer.
I'm mulling over thoughts at the moment.
Okay. Yeah. Well, look, maybe I can give an observation from Australia while people think. And this is a topic that comes up in the stigma discourse quite a bit. And in Australia, in the last 25-ish years, we've had quite a bit of very high-level national discourse around anxiety and depression, fueled very much by our National Depression Initiative, Beyond Blue. And when we look at studies of nationally representative studies of stigmatized attitudes towards, say, for example, depression versus other types of mental health problems that occur with lower prevalence and might carry more severe impairment, come with more complex symptomatology like schizophrenia, for example, what we tend to see is that the attitudes towards schizophrenia are more stigmatized, relatively speaking. What has come up in discourse a lot is this question of, have we actually inadvertently created a problematic dichotomy here where, in focusing so much on the types of mental health problems that are common in the community, and by normalizing those and increasing the discourse around those, have we not only reduced stigma about them, but have we inadvertently othered everything else that's more severe and complex and lower in prevalence? This is something that's coming up, has been coming up for the last few years. I think it's a really interesting idea. Would anybody like to check in with that from maybe your observations in your region of the Asia Pacific?
Yeah, I'm just thinking about all the different stereotypes that are associated with mental health and how perhaps from a public's perception, the layman's perspective, I guess lazy might have been associated with anxiety or depression, whereas the more quote unquote severe ones, being violent, are for the ones that are more serious. I think I agree with what you said. By perhaps having these distinctions, have we inadvertently kind of separated and perhaps stigmatized the more severe ones even more? And I think by having more people with lived experience share the quote unquote more serious mental health illness stories, we can kind of highlight that it really isn't those negative stereotypes, and I don't know, maybe perhaps put them in the same playing field, so to speak, of destigmatizing mental health. Not sure if that
So again, the power of lived experience, of telling real stories.
Yeah, the
sharing.
power of having someone who's truly lived through it to share, what it's really like, rather than from people who haven't.
Yes, yes. I just had a flash of thinking back to my very first placement when I was in undergrad psychology, going in to work with some people in an inpatient facility, and being terrified because I'd never met anybody with schizophrenia before. The first person I was working with was schizophrenia. And then when I met him, well, my goodness, he couldn't have been a more nice person. And it was such a transformational moment for us, for me. When we have the lived experience sections of our curriculum, when people get to hear from Australian ambassadors like Sandy Jeffs and Faye Jackson, who are some of our leading advocates in Australia in our curriculum at Melbourne University, I will get reams of emails saying, I can't believe this. I feel, remiss. I was afraid, and definitely stigmatized. But now, having met Faye and heard about her story, I realize that people living with mental health problems are just like everyone else. There's just something that is obviously so powerful about those really authentic stories, that individuals are complex people, and that have got so much more than simply the experience of mental health that's happening in the context of their lives. It's very transformational for us all to hear and observe and just, you know, be influenced by that common humanity that was central to the findings of the Lancet Commission, and leveraging that power of lived experience and thinking about Elsa's point before, ensuring that we've got representation of lived experience and leadership and co-leadership. These factors are also central to the Mosaic Toolkit, again, from Professor Petra Gronholm and colleagues, that was just released on World Mental Health Day. And we've just talked, or we're about to talk about some tips for services and individuals who are interested in doing stigma reduction work. For anyone who is interested in doing stigma reduction work, I would encourage you to access the toolkit. The idea of this toolkit is to take strongly evidence-based principles and to make them accessible for anyone to engage in effective stigma reduction work. So I think Glenn has just shared the link to the toolkit in the chat, in the webinar chat. So if you would like to click on that link, you'll be able to access the toolkit. It's a wonderful read, just very simple and accessible, but very powerful in its evidence base. So with time winding down, I'm now going to come back to everybody, and there are more questions in the chat than we could possibly answer. However, everyone, perhaps would you be happy to follow up? Maybe we can follow up with some emails afterwards for the questions that we don't get to live. Fantastic. And now let me come to you, seeing we've got so many people from practice initiatives with that question about if you had one recommendation for how to take culture or how culture might be leveraged in optimizing stigma reduction work, what would that be? Let me come to Asami first.
Sure, thank you. What a big question, hey? Okay, I'll speak from the shapes and sounds perspective, especially because we're so concerned about people from the Asian community going to services and feeling like their needs are dismissed or overlooked or unheard. And we hear that kind of feedback a lot at Shapes and Sounds. So if you are on this call and you're kind of thinking about how do I engage the community here, the Asian community here, one thing that I really think about is in Australia, and for those of you who aren't aware as well, outside of Australia, in Australia, the history of Asians in this country is one, a little bit difficult, but also two, we had a lot of immigration from the 70s, which wasn't that long ago, from different Asian countries. We opened up our borders to allow immigrants to come in big numbers. And so our population kind of changed quite dramatically over still quite a short period of time. So what that has led to, I would say, is that there's still like not that much knowledge about the Asian community here in Australia. Like people don't actually know that much about our histories and the complexities within the continent of Asia itself and why people are in this country and how their families are structured and the traumas that have been carried down as well throughout different wars and different conflicts across the continent. So I think base level, really having an understanding of Asia and kind of touching in on the points that everyone on this panel has spoken about, things like Confucianism, things like collectivism, understanding these core concepts that really feed into our identity will help fundamentally in understanding the population here and reaching us, because that understanding will then translate into the services that you offer the messaging that you provide, the visual representation on your websites and on all your marketing material. This base level understanding, it will feed through as well. And I also want to add, if you also don't know too much about what's going on here, I think it's really important for us as a country to remember that we are a multicultural country, but our history is very, very recent. So it's hard for everyone to catch up as well.
Yes, that's such a good point. And just to build on the very last thing that you said, unfortunately, one of our speakers, Manisha Mora from Nokatia Ao in Aotearoa, New Zealand, was unable to make it today. One of the things she was going to talk about was Maori culture and how that informs the work in New Zealand, which is a very old culture. And in Australia, of course, with Australians, First Nations peoples, we've got, eons old culture, tens and tens of thousands of years, time immemorial culture, that we know from recent work from leading Aboriginal psychologists like Tracy Westerman have got very different conceptualizations of mental health problems to that which we might see in the DSM-5, and there being no one-to-one correspondence at all necessarily, and indeed stigma not necessarily even being a concept in some communities based on some of the consultations that I've been involved with. So perhaps in a future webinar, and I think this has been a great discussion. I think it would be great to have more of these. We might be able to look at some of the traditional indigenous culture in the region and dig in there a little more. And I digress a little, but Vicky, I just wanted to touch on that with Manisha being away today. But Vicky, as our other person who's instrumentally involved in service delivery and in stigma reduction initiatives, what would be a piece of advice you'd give about how to take culture into account?
Thank you for asking that question. I think it's by including people with lived experience in the background decisions as well. So the way we run our ambassador trainings is it started off with an English training, and then we graduated with having a Cantonese one. And in doing that, we took a lot of, we took into account, perspectives and advice from our ambassadors who are local. I understand that for myself. I know one of the questions was, how do you tease apart your research and understanding of mental health and stigma with our inevitable Western influences? And I see the bias in myself. I have that too. I wasn't educated in Hong Kong. But I think by including ambassadors who have lived in Hong Kong their entire lives, educated in Hong Kong within a much bigger local context than me, I can also see that including that changes how we do our training and, I guess, delivery of our campaign as well. So within our Cantonese training, we actually have an additional session. It's another evening session, which makes it 5, which is honestly such a big commitment for people to come to at night. And we call it localizing mental health in Hong Kong, which is separate because there are just so many nuances within Hong Kong and our own culture that the expats who attend wouldn't understand or relate to. And we think that it is so important to have this extra session to kind of broaden our scope and to take into, our Hong Kong multicultural aspect into account. So I think the long story short version of that question would be to include people with lived experience from the culture that you want to tackle the issue. And I think that's very important because ambassadors within a more local context have definitely shared advice and experiences that I don't think I would have ever thought of or understood because it wasn't something that I could relate to.
Great advice. That intersection of culture and lived experience, love it. I'm working my way backwards, I suppose, through the lineup of our wonderful speakers. I might come to Elsa next. Elsa, what would be one tip that you would give, one suggestion?
That's so tricky to just leave it at one. But I guess sort of touching on what we've spoken about before. Actually, no, I do want to talk briefly to the an earlier question, sort of how do we tackle stigma for milder versus severe conditions? And I guess firstly, I think it's really important to sort of recognize that most of the time these milder conditions don't occur in isolation, and there is such a high proportion of comorbidity for both for individuals that are experiencing these conditions. And I guess I'm fortunate enough in that I'm very experienced in the all kinds of mental health services in Australia, and having been to, all sorts of them, and you get to see and hear stories about people's experiences. And often, especially when in the inpatient setting, the belief that, anxiety and depression are more milder disorders carry an additional layer of self-stigma in those patients, in that they feel like they're not unwell enough, or they're not sick enough to get treatment. So, but I guess from a advocacy and researcher perspective, it makes sense to start from that, because those are everyday experiences that the general population find easier to relate to. So I guess tagging on, then, what do we do for the, lower prevalence disorders? And I think it is very important to have lived experience representation to speak about them. I still remember my mum going one day. I can't remember what it was for. It was like, I thought people in, like, with addiction were all, bad or scary, and then I realized they're not. And it's when you've had, I guess, when you've met people that have experienced these more so-called severe disorders, but they are still, functional members of society. They don't have to be they don't even have to be, fully recovered per se, but it's more that um they are just like a contributing member of society, like everybody else. I think that's really important.
Yeah, very powerful. Again, lived experience shining through. Now we're running out of time. We're going to maybe go slightly over by a minute or two, but to bring us home, Ethel, what would be the one suggestion you might offer for those interested in stigma reduction?
Okay, I think I'll start on the more research side first. So to answer the ethnographic question, I do think qualitatively we need more ethnographic research where we can actually study the lived experiences. So that's part of my PhD as well. And I'm starting to realize that we often focus on people who have overt differences in terms of their appearance and so on. But in ethnographic research, we might be able to find that, there are people who live experiences who look just like any one of us, and they are actually not stigmatized. So ethnography can help in that, because it really studies people's interactions in real life and natural setting. So that's for one. And practically speaking, interventions wise, I'm recommending that we could actually put social capital into the picture. And part of social capital is really about encouraging more civic engagement. And I'm suggesting, and I'm also trying to study how civic engagement through volunteerism, such as encouraging people to volunteer more with the sector, can actually bring people to come into contact with each other in a more natural kind of setting. And because we know in stigma intervention, contact types of intervention has been found to be the most effective. So civic engagement through volunteerism is one of the key ways that we can bring people to interact in a more organic manner to reduce stigma, hopefully. And the other thing about volunteerism is not just like members of the public sort of volunteering to sort of in the sector itself, but also volunteering from the people who live experiences, because that would actually put important roles into their life. Because based on what I found, those people who actually had all these important roles or some roles of sorts that matter to them, it gives them a sense of like satisfaction, as well as we call it sense of mattering. And I actually found this unique group of people who were able to not self-stigmatize precisely because they could do something and to sort of serve others. So in a nutshell, that's my opinion.
Oh, that's and a wonderful opinion it is, Ethel. I love an evidence-based opinion, and it's just so interesting. I didn't anticipate this before the webinar, but we've seemed to converge on this idea of lived experience and its power in shifting stigma across the Asia Pacific region. But of course, this is a global issue. And while we've run out of time on this webinar, I hope that there are going to be many more, because there's just so much more that we can talk about. So everyone in the audience, I think you've got a react button. You might like to thank our wonderful panel of Elsa, Ethel, Vicky, and Asami. Thank you to Glenn for, again, driving the creation of this webinar, to Dr. Anne-Claire Stoner for, again, being instrumental in the setup of this webinar, to the Mental Health Innovation Network Asia, and to the Global Anti-Stigma Alliance, to Michael Petrus, Michelle Blanchard, Samantha Grabell, and all of the members of the Mental Health Innovation Network and Global Anti-Stigma Alliance. I'd also like to thank, again, Dr. Kate Mandeville, Jason Allport, and the team from the World Bank for bringing us all together in the first place, and really starting to work around this issue of stigma in the region. Again, for everybody who would like to learn more about leveraging the power of lived experience expertise in stigma reduction work, please go and see that link to the World Health Organization Mosaic Toolkit to help you in your work in addressing stigma and discrimination about mental ill health. Thank you very much to everyone who came to attend the webinar. We appreciate it. We hope you took value from it. Take care of yourselves and each other, and we hope to see you for another webinar very soon. Take care.
Thank you, Dr. Chris, and everybody else on the panel. This was a great hour and a half. I just wanted to make a note that we have the QR code on the screen right now. If you could scan it and kind of leave us some feedback. If you want to hear more about the topic, that's also a great place to let us know that there's a hunger for this topic, and we will try our best to feed that hunger. I also wanted to note we did have a lot of questions that we didn't quite get to, and as Dr. Chris mentioned, we're compiling the questions. We'll send that out to our panelists, and so we can get some written responses, and we'll try to disseminate that through along with the recordings of today's program as well. Yes. Other than that, thank you very much, everybody. Have a great rest of your day, evening, wherever you're joining us from.
Thank you all.